It's my pleasure to introduce Dr. Cherie Erkmen as our Division of General Thoracic Surgery Distinguished Visiting Professor. She almost didn't make it. She missed dinner last night because her connecting flight was in Phoenix, and her flight was delayed because of the Super Bowl. And so Patrick Holmes strikes again. Dr. Erkmen is a thoracic surgeon, professor of thoracic medicine and surgery at Temple University in Philadelphia. She has been named as a Philadelphia top doctor. She is also the director of the lung cancer screening program and the thoracic surgery residency program. And she carries the additional title of professor in the Center for Asian Health. She has experience with surgical treatment of lung cancer, chest wall tumors, GI and pancreatic cancers, and other lung and pleural diseases with expertise in minimally invasive surgery. She has unparalleled expertise in the efficacy and equitable application of lung cancer screening, in addition to diversity, equity, and inclusion in patient care, as well as workforce development. Recently, the STS the Society of Thoracic Surgeons had a bit of a crisis in DEI, and one of the individuals whose expertise they sought to create a path forward for the organization and specialty was Dr. Erkmen. Dr. Erkmen is a daughter of California, having done undergraduate at Cal. Neat little fact, we were in the same dorm together at Berkeley, and she hung out with the cool kids. And medical school at UCLA, back when UCLA was in the Pac-10 as opposed to the Big Ten. She then traveled to East for general surgery and cardiothoracic surgical training at the Brigham and Women's Hospital. She was recently received an honor from the Women in Thoracic Surgery, and she was nominated anonymously by one of her trainees. As highlighted in her anonymous nomination, Dr. Erkmen is a true role model for her residents and fellows. Not only is she an amazing surgeon, but she always takes time to teach on the wards and in the operating room. Her dedication to her patients and learners and passion for her job are palpable. Not only that, but she is a dedicated mother and sports fan. She is truly well-rounded. Again, I would like to thank you and introduce Dr. Erkmen.
So thank you so much for the opportunity to be here, and Dr. Farmer. So David Cook and I actually met when we were both applying for cardiothoracic surgery fellowship. And so it's interesting how these chance encounters can get you on a path where I am able to see his career for several decades now, actually, and see that he is truly a visionary and a change maker, not only in our field and surgery altogether. So it is a delight and an honor to be here. I can't tell you how excited I am to be here as a visiting professor, but the true irony is that I probably have slept through more visiting professor lectures than anyone else in this room. And so if you fall asleep, it's okay. However you choose to spend the next hour with me, awake or asleep, I hope it's enjoyable. So with that, disclosures, relevant mostly health disparities grants. And looking at the talk today, I kind of wanted to divide it into two different parts. One is to give an overview of lung cancer screening and disparities, just to give you an idea of the context. And this multi-level assessment, forget about that for now, we'll get to it. But it's basically a way that my team addresses the issues of disparity in lung cancer. So lung cancer deaths yearly, if you think about it, so we just tried to get over the Super Bowl. If you fill up the entire Lincoln financial field and you fill up all of Citizens Bank Park with our World Series appearing Phillies, and you fill up all of Wells Fargo Center, and you throw in your 200 season ticket holders for the Flyers, then that still doesn't equal 127,000 deaths yearly. This is a huge number. A different way to look at it is that you have 382 deaths daily. That's the size of 777 crashing every single day, and that's attributed to lung cancer. Lung cancer kills more people than breast, prostate, and colon cancer combined. And yet the federal research funding is just a fraction of that. So our first take-home point is that the stigma of lung cancer impedes progress. The stigma of lung cancer is this. I mean, everybody knows that the pink ribbon is for breast cancer. Does everybody know what month is Breast Cancer Awareness Month?
October.
It's October. What month is lung cancer awareness? Nobody knows? It's November. What color is the lung cancer ribbon? It's white. It's not even a color, right? That's not fair. And actually, in some Asian cultures, white is the sign of death and morbidity. So imagine you're wearing that on your jacket. Your lung cancer patient comes in to see you. Why are you wearing that white ribbon? I'm wearing it for you. Signifies lung cancer. So, it's the stigma goes deeper, because if you ask a lung cancer patient how many times they're asked if they smoke, it hurts. You have lung cancer? Oh, did you smoke? Would you ask a breast cancer patient, did you take hormone replacement? Or did you take oral contraceptives? Because that's a risk factor. Or someone who had an MI, well, did you eat a lot of hamburgers? But somehow it's acceptable with lung cancer. I think it's not, but that's the stigma, and it impedes our progress. Lung cancer also has the stigma of being lethal. So that is because 75% are diagnosed in late stages, where the life expectancy is about 6.3 months. If we can diagnose it early, we're looking at 85% 5-year survival. Most people live beyond 5 years. So is there a way that we can push this proportion to early diagnosis? And that way is through lung cancer screening. This is a landmark study, 54,000 patients, annual lung cancer screening with a low-dose CT scan reduces lung cancer mortality by 20%. And something really, really interesting about this study is that it also decreases all-cause mortality. This is the only screening study, the only screening to demonstrate an impact on all-cause mortality. And so this is kind of a busy slide, but it shows you early in the 1980s, when we're well on our way to mammography and colonoscopy, that the American Cancer Society does not recommend lung cancer screening. It just doesn't. So we skip forward to 2011, and we see this landmark study of 54,000 patients. By comparison, we're looking at Framingham's study, 5,000 patients. So this is very compelling information. And U.S. Preventative Services Task Force says this is great evidence, you should support it. So then just a history of how things work in policy is that CMS says, okay, under strict guidelines, we should cover it, but only after a cost effectiveness analysis was done. So we have to wait 4 years before lung cancer screening is actually covered. One of my mentors at Dartmouth was the one who did that cost effectiveness analysis study and published it in the New England Journal of Medicine. He had that data in 2011, but years and years of review, 3 years, it took that much time to get it through. But even then, the guidelines from NCCN were a little bit controversial because they said that we're not capturing everybody. So we have different sets of guidelines. COVID happens in 2020. We get more data from the Dutch national trial that it decreases lung cancer death, that lung cancer screening will help. But things start to align in 2021 and 2022. Family physicians support lung cancer screening now after 10 years. U.S. Preventive Services expands criteria, NCCN guidelines come into play. So right now, in 2022 and 2023, everything seems to be aligned, which is great. Our screening guidelines greater than 20 pack years, actively smoking or quit within the past 15 years, and age 50 to 70. People forget about willing and able to undergo lung cancer treatment, but that's really important from the screening perspective. But the problem is that we have very low uptake of lung cancer screening. We're talking about 6% of people eligible are actually getting screened. That's today. So that's our second take-home point. Lung cancer screening saves lives, but 93% of those who are eligible are not doing it. This is a huge problem. So lung cancer care, just like all epidemics and pandemics, disproportionately affects vulnerable populations. So this is a hard slide, but the dark blue bar is white Americans. And early diagnosis is less in all other races. Surgical treatment is less in all races except Asian. But lack of treatment altogether, people who just don't get any treatment for lung cancer, is higher. And even stage 4 should get treatment, palliative care. So let's drill down onto this idea that African Americans have a higher incidence of lung cancer, diagnosed at a later stage, lower chance of receiving treatment, higher mortality. But the good news is that lung cancer screening is even more effective in African Americans. So that study showed that they have a greater reduction in lung cancer mortality, greater reduction in all-cause mortality. So this is a way to close that gap of health disparity among African Americans. Unfortunately, low representation in screening trials. Less than 5% of people in the trial were African American. White Americans are 3 times more likely to participate in screening than Black Americans. Low adherence to annual follow-up care, 30% versus 95% in the trials. And the screening criteria doesn't include people who are at high risk with a lighter smoking history. So African Americans are not accessing lung cancer screening. This was our pathway to decrease that gap of health disparity. But if we cannot access that, if we can't deliver it, it actually becomes a mechanism to widen that gap. This is a terrible and important concept, that lung cancer screening can exacerbate health disparity if we can't deliver it equitably. So what can we do about it? So I was at Dartmouth, and I helped transition the group from a screening trial center to an actual clinical program, and then recruited to Temple. And I thought, I can do this. I know how to put the pieces together. I know how to get the right stakeholders involved. I have developed educational information. I can do it. But what I didn't know is Philadelphia. Philadelphia has a poverty level that is profound. 45% of people live below the federal poverty level. That is $25,000 for a family of 4 per year. 55% of our children are in poverty. 86% are Medicaid or Medicare. This is a map of Philadelphia. This is poverty by zip code, and Temple is right in the middle. We have Penn over to the west, Jefferson north and south, but we're in the middle of, if you put a map of violence, gun violence, death, crime, smoking, it's the same map, and Temple is right in the middle of it. Also part of this was this very rigid lung cancer care paradigm. Everybody stays in their swim lane. Risk assessment is a primary care issue. Lung cancer screening, we don't know yet, but diagnosis, treatment, we all stay within our lanes, and that has led to the disparity. So let's break this idea up and not think about lung cancer in terms of our specialties, but think of it as a patient-centered strategy, that we look at the patient, the provider, everything centers around this concept. I'll give you an example. So smoking should be primary care, right? They're the ones who are dealing with it. Let's throw you some nicotine patches. It's unfair to burden the primary care with all of this because we are fighting up against decades of aggressive marketing. First of all, putting nicotine into the cigarettes to make sure that they're addictive enough that it's ongoing. Aggressive marketing campaign. I don't know if you can see this. It says, blow in her face and she'll follow you anywhere. The doctors are smoking Camels. So this is aggressive marketing and to targeted populations. So cigarette companies knew very well that map that I showed you, that exact map, that's going to be the guide of where we're going to focus our marketing. I have a patient who said they used to send me dailies with free coupons for cigarettes. People were getting this in their mail. They were getting it in the newspapers. Free cigarettes. Bodegas, little stores on the corner, all of them have all the cigarettes. High concentration of vendors. Sponsorship. A lot of the cigarette companies are sponsoring entertainment, politicians, NAACP, even HBCUs and scholarships. It's an iterative process that goes. So we're fighting this. And we're saying, okay, primary care, deal with it. This is going on now. Do you think that this is something of the past? Just in April, the FDA said that they condemn egregious targeted marketing. It's still going on. Philadelphia has the highest rate of smoking, and now what do? So we re-envisioned lung cancer screening, and every single person on our team went through at least a week's worth of smoking cessation education, because that's patient-centered. That's where patients are. We did a community health needs assessment, and we just asked them, okay, what's going on? This is Farouk Dako. He's now an attending radiologist at UPenn. We went into the housing communities. We went into churches. We did focus groups, and we learned that people are worried about lung cancer, very worried. They know about screening, so we don't have to waste time on that. They already know about early detection. But when we told them what's involved, the low-dose CT, then you get the results, they're like, that's too many steps. There's no way we can do that. But they told us that they need support with smoking. That was very profound. That we continued to go on with another assessment. People really thought that it was a death sentence, that lung cancer was a death sentence. But they're willing to learn. Money is a barrier. So what did we do? We developed these, I don't know if this will work. I don't think this will work. Podcast, patient stories, education and engagement. It may work. Hold on one second. No, it won't. That's okay. We went to our local media to do education and engagement. We had webinars during COVID. This is Kenny Bonnet. He's a medical student. He's actually working on a health app to help people get to screening and stay compliant. We went out into the community. We got contracts with the Philadelphia police, the firefighters, and the carpenters for screening, to give them an impetus, a community to say, yes, we need to screen, we need to support it. We went to the Phillies game, good year to go to those. We also went to something called block captains. So in Philadelphia, each community has an elected block captain, and that person goes to meetings regarding, this cracked sidewalk or garbage, but also health issues. So we're reaching out with students and residents, actually. This is George. He is a Philadelphia police officer, and he has a short video. It's genuine story, relatable, a call to action. Don't be afraid of lung cancer. Get screened. And so this has helped us. We also are trying to lower the barriers between what is screening and what is treatment. So we actually had the robots wheeled into our lobby, and high school students and college students come in and play on it. Everybody, it's open to everybody, and just to get people a feel for what is treatment. And so that's from the patient side. Then we also need to look at the provider side. We did an assessment of the providers. This is Rachel Kim. She's now a thoracic fellow at the Ohio University. She found that people just weren't screening. They have more urgent issues, they're limited. As 64% didn't even know how to go about it at Temple. Yeah, you do a low dose CT, but what does that mean? Nuts and bolts. So we did a lot of provider education. This is Jonathan Nitz. This looks like a high school photo. I don't know why he sent this one to me, but he doesn't look like this anymore. He has 5 children and is a thoracic fellow in Boston. But he wrote a nice article to show how we can advance lung cancer screening and decrease health disparities. This is Catherine Ortmeyer. She's a resident now at Emory. She was one of my medical students, and she did this prospective trial looking at different ways to educate people. So we could do lecture, just like we're doing now. It's very easy. You sit there and learn. But another way to do it is to throw you into different groups and give you these challenge problems. And you're able to look it up on your phone and go through the exercise of challenging problems. And the knowledge, people enjoyed it more. The facilitation of implementation was all better, but it takes a lot of effort. But at least we know that there's pluses and minuses, and one way isn't better than the other, but a mixture is good. This is Shelby Safara. She's now a general surgery resident at Cornell. She was a basketball star. She doesn't know that I put this slide up there. But she did a study to compare 2 decision-making tools. So these are actual tools that you talk to your patients about lung cancer screening to guide that decision. This is a web-based tool out of Michigan. This is one that we developed at Dartmouth, where it's kind of like a FAQ, and you go through this. Both are good. They're great. Some of them are more time intense and they get more value out of it. Some of them are just quick and dirty, but they both work. And we also developed a rapid single visit program where we work out your insurance, you get shared decision making, you get the CT, and you get the results on the same visit so that you decrease the number of visits. So I did a lot of begging with radiology to make this happen, and they did. So 1 year, come back. If it's negative, if it's positive, we give you the next steps. So this is how we overcome it on the institutional side. And Temple lung cancer screening, as you can see, increased. There's a little dip with COVID, but we have been able to increase our screening numbers year by year. 3% of people receive a cancer diagnosis, and you have to tell people about the risks. So what could be risky about a CT scan? You just go in and out. But false positives are the main risk, about 10%, that you're told you have a positive screen, but you don't really have cancer. Even more harmful is that maybe you'll get a biopsy or a surgery for something that wasn't cancer. And so you have to tell your patients this. And this is Simran. She is now an attending at the University of Colorado. She did the larger study of 1,500 patients and marching it out. She looked at a sub-analysis of women and found that it's more effective. Lung cancer screening is more effective in women, actually. And this echoes what we saw from the Dutch national trial. And here she is with Dr. Rove, who is a cardiac surgeon. They did heart and lung transplant on the same day. This was their first one together, and they sent this picture to me. So patient-centered lung cancer screening is feasible and sustainable, and that's the next take-home point. They're not all successes. This is a big fail, that people don't come back for their lung cancer screens. It's not just a one and done, yay, I'm good, no cancer. It's annual screening. It has to be annual screening. More than 50% of cancers detected in that big national trial were on subsequent screens. And 90% of people followed up with those annual screens in the trial. At Temple, it's about 20 to 30%. It's terrible. This is a terrible fail and something that we overlooked. So this is Mark Lee. He was a medical student who did research with me, and he's now at Stony Brook. He found that 30% believed that they were low risk of cancer, even though they had lung cancer screening once, even though we supposedly educated them on lung cancer and their risk. They believed that they were actually low risk. And the knowledge level was lower when we looked at it by race. So that's bad. This is Jess Magarino. She's one of our current residents. She used telemedicine during screening. We're using telemedicine now to try to get people back to their annual screens and trying to find new ways to overcome this. And then, of course, Simran and Farouk, this is circling back, breaking down these swim lanes and silos of care. And as a radiologist, you're a public health practitioner. As a surgeon, you're a public health practitioner. That this is how we should re-envision not only lung cancer care, but maybe other things, right? One quick thing about the institutional barriers, we do have to say that at the institutional level, we're thinking of money, right? So they invest in this multidisciplinary lung cancer program. They want to collect. They want to drive downstream revenue. Unfortunately, this is Lindy Lutzow. She's one of our residents now. She did a study that showed that $260 is about what we're billing. We're only getting back $42. And 20% of those lung cancer screens are not even collecting a penny, nothing. It's not better for colon cancer or breast cancer. And at the institutional level, it's poor incentive to support screening. And this is a problem. One note, we found out that 1.5% of people who did lung cancer screening were sent to collections. Their insurance didn't pay for it, even though, CMS says we're paying for it. And so our patients, we just kept reassuring them, no, it's covered, you're eligible, don't worry. But unfortunately, 1.5% were sent to collections. So we have to fix this. So when we think about the failures of low uptake, it's not just the patients. Oh, the education, you need to come in, or the providers, you didn't write that annual screen order. It really is a burden of all of us. So you're getting tired of these circle imageries, but multi-level mechanisms of disparity mean that we need multi-level interventions. So at the macro environmental level, we're looking at how can we make a difference. So we need to change policy. We need to be part of policy that's driven. So that really busy slide that I showed you, CMS, U.S. Preventive Services Task Force, all of those have open public comment statements. So they open the forum, and we need to be part of that process. We need to drive it. Many advocacy groups out there through your professional societies, and also in a diverse workforce. So we need you to do this type of research. Right now, the phenotype of research and funding dollars is white men, established research, late in their career, and looking at more metastatic and advanced cancer. But we need people from diverse backgrounds, students, trainees, early career people, people with clinical relationships and community relationships. Why? Because it drives perspective, innovation, commitment. This is well documented. So our research workforce has to be populated with a diversity of people. This is a partnership we have with a foundation called Longevity to promote clinician scientists in health disparities. So we have underrepresented in medicine students in their first year, and we bring them through a training program over their summer between the first and second year, and all three of these students have continued to work through their second year on projects. Our clinician workforce, Dr. Cook talked a little bit about what we know in cardiothoracic surgery, 17% women, 12% URMs. It's bleak. And we have a really good study by one of our colleagues who showed that there was a lot of abuse, discrimination, and harassment going on in the workforce, and salary disparity. For every dollar that a man makes, a woman will make 77 cents in cardiothoracic surgery. For every dollar that a white person makes, it's about 80 to 90% for any other. So this disparity in the clinical workforce is also driving the disparity that you see among patients. And think about LGBT. This is Erin Ajelko, one of my residents, who explored the inequities in surgery, both from the patient and the provider side. So, okay, more circles. You're going to get tired of this, but this is a thoracic surgery STS approach to diversity and inclusion. Again, using this paradigm of at the individual level, provider level, institutional level. And I think there's an appetite for learning about health disparities in thoracic surgery. There's been an issue looking at all different health disparities in esophageal cancer. We, as surgeons, bring a unique perspective to health disparities, and we have to be a part of this in the future. So that's the last take-home point. And how does this relate to you? It's not just for lung cancer care. This is a way to think about any disease process, and specifically any disease process that has health disparities. So this this concept, this conceptual framework comes from the National Institute of Health and Minority Diseases that helps to guide how we structure care for the future. So thank you very much, and I'm happy to take questions.
Well, I just want to thank you, Dr. Erkmen, on a fabulous presentation on so many levels and so relevant to a lot of the work that we care about here at UC Davis. Gosh, what a transition from Dartmouth to Temple, and how important the environment is that you're working in, and how to be sensitive to making an impact and a difference in your community. Really great. Thank you for being here. I've got one quick question, and we'll open it to the audience. I noticed that Dr. Kaiser was on a lot of your papers. Is he still in a leadership role at Temple?
The answer is no.
I was just going to say, for a guy that kind of runs the health system to be in the papers, I would have told him that he should not be charging his people for lung cancer screening and sending them to collections if they don't pay. But maybe we can talk about how to deal with that later. Yeah. But it's an interesting thought. It made me think, gosh, we could actually fix some of those things. Let me turn the podium over to questions. We've got some time here.
Hi, Kurt Wozniak. I'm a cardiac surgeon. I started off doing cardiac and thoracic surgery, and worked a lot in the VA system. And we dealt a lot with lung cancer screening and a lot of ground glass opacities and such. In the VA, we had, I would argue, pretty good capacity to track the nodules, to get follow-up, et cetera, et cetera. In these red circles in downtown Philadelphia, How do you sort of get over the problem of all the downstream sort of follow-up care and all the other things that are involved once you've got someone into the screening program?
So it's an easier question as we were beginning because we know by proportion about 12% of people will have positives. So everybody else who's negative, we kind of neglected. And so if you're negative, you're good for now. And then we put a lot of resources into those people who are positive. And they got their results right away on the same day that they got their screens. And so that was the day that we wrote the orders for PET scan, for consultation with pulmonary or interventional radiology. And so that single visit paradigm helped us set the wheels in motion so that we wouldn't lose track of those patients. So we made that a priority. The loss to follow-up of positives, we wanted that to be a very low number. So we were good about that. 100% of our positives in the first year came back, but after that first year, it deteriorated to, like 2%. So we're having a huge problem because as the program grows, do we have the capacity to deal with it with such, intensity? And it remains to be seen. It's a really good question.
Right. Thanks so much. I remember we had a lady, that was her sole job in the VA. The nodule database. She just ran a database of all these patients. So fabulous talk. Thanks for coming out.
Thank you.
Dr. Godoy.
Thank you so much for coming out and giving us this great presentation. And as bleak as the numbers are for lung cancer screening in general, in California, we screen about 1% of eligible patients. So we rank 50th in the country. So one of our goals here at UC Davis, yeah, nowhere to go but up from here. One of the goals is to help to change that trend in California, since we're a health conscious state. And one of the goals down the road is to help work with legislation. And since we're here in the capital of California, we have easy access right down the street to the Capitol building to work with politicians to help increase the numbers of screening and help to get some funding for these projects. Have you guys encountered any difficulties with working with legislators, or have you worked or partnered with any of the leadership in the state?
We have with our state representatives mostly, and with our state public health group, that we've done a lot of shared presentations where they're focusing on smoking cessation, and we're giving the follow-up of lung cancer screening. So there have been some partnerships, but at the higher level, I think that it goes back to point number one, is that the stigma of lung cancer is impeding this. And I think that's probably in play in California, is that people think that, oh, this is a healthy state, it's not something that is in our priority list. And so changing that concept that, the smokers should be punished or they deserve lung cancer, that stigma you really have to overcome. And so anything at the higher level where we're talking to policymakers and lawmakers, we're bumping up against that. So I've had more success working with the public health groups than politicians.
So I think that's a call to arms to our group. We have many residents who are interested in public policy right now, and our SRS group is always looking for projects. And I think, make a comment and you get tasked to be the leader. So I do think we could make a difference.
Good morning, Sabrina Evans, cardiac surgery. So thank you very much for your talk. I think it was very important points. And one thing that I've noticed here is I work very closely with the TAVR program, doing the transcatheter valves. And so every single one of those patients gets a CT scan. And I've diagnosed a surprising number of patients with lung cancer just by personally reviewing the CT scan that was actually either missed by the radiologist, or the person who's primarily responsible as the cardiologist at that point in time felt like that was something we could, quote, deal with later. provider and didn't really refer that to the provider. So part of that, I think an opportunity for intervention is education of the other providers, or perhaps even just having some screening tools on the imaging protocols themselves to have an automatic referral to a primary care provider if a nodule or something has been found. Yeah,
Yes,
exactly.
which I know, for example, that Dr. Campbell put in place for incidental endocrine tumors, and I might connect you
Yeah.
guys to see if we could do something similar.
Yeah, so that was kind of an interesting thought that I had just thinking through that and listening to your presentation. Have you guys had any experience or similar situation at your institution?
Yes, very much so. So one of the things we have to do, again, is to break down these siloed ways of thinking of caring for patients. And we have a program with coronary calcification and low-dose CT for lung cancer screening. And the CT scan that's low-dose is pretty good. We did an internal study that shows that you really only need one low-dose CT scan to get that information. But even more importantly is that the shared risk factors of smoking and lifestyle can receive the same information. And so instead of thinking about, coronary calcification screening, lung cancer screening, preparation for TAVR, surveillance for aortic aneurysms, like all of that can be patient-centered and, okay, patient, you only need to undergo one scan a year, and all of us can use that information and try to drive this patient-centered, cost-efficient, care-efficient paradigm.
So I have a question related to what appears to be an increasing incidence in young women, particularly young women non-smokers I've seen in the literature. And I have to say now that I personally know two female chair-level people younger than myself who have lung cancer. So what's going on? And should we be changing our screening criteria? It seems pretty stringent.
It is. We know that 32% of people who have lung cancer are not qualified to get lung cancer screening. So we are missing a large proportion of people who are getting lung cancer. They're obviously at risk. So how do we balance that? Well, why don't we just make lung cancer screening available to everybody like mammography? But unfortunately, that makes it like instead of looking for a needle in a sewing basket, you're looking for a needle in a haystack. And so it changes lung cancer screening's accuracy. So we have to be really careful about expanding the criteria, but at the same time, I think right now we're too stringent, I think. So what's going on? There are lots of different paradigms of lung cancer. We have a large proportion of women, non-smokers, who have lung cancer, as well as Asian non-smokers who are getting lung cancer. So we are acting as if it's one disease, and it's certainly not.
I really like the idea of using the one CT scan to screen for all these diseases. You're right. It's really silliness. All right. Before I turn it over to, I just want to make one quick announcement, which is a reminder that our department's research day is coming up, and the deadline for abstracts is February 24th. Is that correct, Dr. Cockett? February 24th. So write that down. And let me turn it over to Dr. Cook.
Great, thank you. I just want to remind, we have over 70 people online. Do we have any questions from the online audience? So, one comment/question I want to have, Dr. Erkmen, is so our executive DI leader at UC Davis Health, Hendry Ton, talks about patient trust. And one thing we noticed during COVID-19, our patients don't trust us. And he talks about in order to have patient trust, you have to be trustworthy. And that takes time. It takes, it's not just at the time of a crisis, but it takes careful deliberation and community outreach to develop that trust. And it's clear in your presentation, you've had a thoughtful approach of going into communities where people live, not only from an education standpoint, but a community partner participation standpoint in order to gain that trust of your community to increase lung cancer screening. So coming from Dartmouth to a new environment at Temple and Philly, what was your strategy? Was there infrastructure in place to help your team go into the community? And what was the strategy for your approach to gain that trust?
We did not have any infrastructure at all, and in retrospect, I kind of regret not documenting what we did more carefully. But you saw Farouk Dako. He and I just kind of went into the communities and just started listening and finding people who could be trusted messengers to lung cancer screening. So it's not just the two of us going into the community, but you're interested in health, you're a block captain, would you like to learn more? Let's meet, let's get you on our meetings, let's get you on our advisory panel for this grant. So really trying to get trusted messengers to get the word out, not just us. So that would be my best advice.
Great. Any final questions? Well, thank you very much for visiting us. You have a busy day planned, including meeting with our trainees. We do have a little bit of a gift for you here. It's a big hunk of crystal that I think turns green if you rub it, and it's good luck. And we really appreciate you being here.
Thank you so much.
Thank you again. Thank you for the great presentation.